Welcome back to the Misdiagnosed Woman. So today we have Ricardo Miranda. He is the CEO and MTHFR consultant for MTHFRdoctors.com. He has done extensive research in the MTHFR area. Ricardo coaches doctors from all over the country on how to treat patients with MTHFR mutations. Ricardo is an integrative medicine practitioner with 25 years of experience, and he incorporates functional medicine, genetics, nutrition, Chinese medicine, and acupuncture in his practice. Welcome, Dr. Miranda. So I want to say this really quickly about how speakers come to an event like this. So for me, there were people that I was already following in health, and there were people that I reached out to that I just admired their work. I had some people reach out to me when they heard about the Misdiagnosed Woman, and that was really exciting. But Ricardo Miranda here, I searched myself for it because I don't think there's enough information in the world, especially and I just don't think there's enough awareness about MTHFR. So I did a lot of my own digging to find you, and I was really excited to do that. So, so you've not done any summit like this before, or a series like this before. So I want to just first off start, why don't you tell us what MTHFR mutation looks like? What is it?
Okay. Thanks for having me here, Shanna.
Yes, of course.
I'm going to try to give as much information as I can. I did find a lot of people who don't know much about it. A lot of doctors don't know much about it. So MTHFR stands for Methylenetetrahydrofolate reductase.
Yes.
Then the number one thing is the gene that helps metabolize folate and folic acid. Now, folic acid is a form of folate. Right. And you get most of your folate from leafy greens like the broccoli, spinach, and folate is the main fuel for methylation. So I don't want to get into too technical here, but this is the intro on MTHFR or what is MTHFR.
Mm-hmm.
So I'm going to go right back to you and see what questions you want to.
Sure. So when someone has a mutation, what does that look like symptomatically? What kinds of things manifest themselves in their health if they have a mutation?
Okay, very, very good question. Because our body, methylation affects, every part of our body. So their symptoms could be, you can have 200 different symptoms. So
okay.
You're not looking for a particular symptom for MTHFR, but MTHFR, the most common ones, but it's not only MTHFR, you're going to have fatigue, you can have headaches,
sure.
But I would say we're not looking at symptoms.
Yeah.
MTHFR, the two main functions for me for MTHFR that affects your body is one, detoxification, because methylation controls intracellular detoxification, and the MTHFR mutation will affect methylation. So let's look at methylation. The number one thing is detoxification, how your body detoxifies. And we live in a toxic world.
We do.
Our foods, we have GMOs everywhere. You got pesticides if you're not eating organic foods. So everyone will have a different detoxification ability.
Yes.
And it depends on the person's lifestyle as well. So if you already have some other health conditions and you're not detoxifying well, then you have an MTHFR mutation, that will be worse. So that's one of the main functions, detoxification. The other one is gene expression.
Okay.
Methylation regulates gene expression. It can turn genes on and off. So if you have a gene, which comes to, if it's okay with you, I'll tell you how I started.
Oh, absolutely.
With that, because that's about gene expression for me. I've been practicing for like 25 years. And the last 10 years I incorporated functional medicine in my practice and genetics. And I went to this lecture on epigenetics.
Okay.
And for me, it was a turning point because we had this concept in the past that what you have the genes from your family,
Yes.
you have genes for a particular condition, that's it. You're going to have that condition because it's in your genes, right? That's
Sure.
what everyone had.
Sure.
And then I learned that the DNA is not, your DNA is not your destiny. That we can actually, we have the ability to turn off those disease genes that are in, that we inherit from our families. So for me, that was phenomenal. It was an eye opener.
How long ago was that?
About 10 years ago.
10 years ago. 10 years ago. Okay, that's awesome.
Yeah. So so I started studying it.
Yeah.
And so the first question in my mind is, that's great. We can control gene expression. So we can turn off those genes. Now, how do we do that?
Yeah.
And the answer is the process that turns off the genes is called methylation. Okay. Methylation controls gene expression. So I say, that's great. So I start studying about methylation. Now, how do we control methylation? You know, and then I found out there are several genes that affect methylation, over 20, but the number one gene that controls methylation, that affects methylation, is the MTHFR gene.
Okay.
There, every supplement we take is a cofactor for a specific biochemical reaction in our body. And MTHFR helps our body process folate, right? Folic acid is a type of folate. And that is the main fuel for methylation. I was like, oh, okay. So if you make sure that your body has enough folate to fuel methylation and make sure that everything else in your body is working pretty decently, you'll be able to control methylation.
Wow.
That's actually the number one factor for methylation.
It's folate.
It's folate.
Folate. Okay.
So maybe I would like to share one thing, not only for patients, but for also doctors, because a lot of doctors are getting into MTHFR, methylation, and there's a misconception that I see out there. Is
yes.
People think that homocysteine is the marker for methylation.
Okay.
Now, homocysteine is an amino acid that could be inflammatory, especially for the heart, connected to heart disease and so forth. And MTHFR mutation will affect homocysteine, will elevate homocysteine. And a lot of people look into homocysteine as the marker for methylation. If your homocysteine is elevated, it's higher, okay, your methylation is not working. If your homocysteine is good, okay, your methylation is good. But it's not necessarily true.
Okay.
So methylation is not the best marker for
homocysteine.
Not the best marker for methylation.
And homocysteine,
I'll tell you why.
Is homocysteine, is this a blood test that someone would do? Like,
yeah, you can take a blood test and ask for homocysteine. It's an amino acid that could be inflammatory and is very much related specific to heart disease.
So if it's elevated, is it assumed then that there's a full methylation, like a methylated
problem?
Yeah, right. Thank you.
Most of the time, yes.
Okay, but if it's normal, it still could be. It's still. Yeah.
And I'm going to explain why.
Right.
Because a lot of time practitioners, let me look at your homocysteine. Oh, homocysteine is normal, so you're fine.
Okay.
Not so much so, because just look at MTHFR. If you have the MTHFR, let's say the homozygous mutation on C677T, which makes you lose about 70% of your ability to metabolize folate, will cause elevated homocysteine. Right?
Can you do that one again? What is it again? The
MTHFR C677T. It's one allele, the main important allele of the MTHFR gene.
Okay.
So I'm going to give you an example.
Okay.
If you have a double mutation, so I'm going to speak on common terms, which we call homozygous mutations. A double mutation will cause you to have most likely, most of the time, will cause you to have an elevated homocysteine, right?
Yeah.
However, there's another gene, for example, is the CBS, is the cystathionine beta synthase, which the allele C699T, if you have a double mutation there, it causes the homocysteine to drop.
Okay.
So
Interesting.
you could have a homozygous mutation on MTHFR C677T, makes your homocysteine go up, but a double mutation on CBS C699T, your homocysteine goes down. So the homocysteine is going to look normal,
Okay.
but you still don't have enough folate to turn homocysteine into methionine and to make the methylation cycle go. So you're still under methylating. But
Okay.
you look at a homocysteine and your homocysteine is fine. So that's just one example.
Okay.
For that reason, homocysteine, although as practitioners, yeah, you should look just to have an idea, but it's not the best marker. What is the best marker for methylation? It's folate. Simple.
Folate.
Okay. So that's a thing. One thing that I want to come across, and also help practitioners that are just getting into
Yes.
this.
Yes.
Don't be locked on homocysteine as if it's normal, it's okay. No, you gotta look at folate.
Folate.
Yes, that's the number one. Okay. Now the other thing that also for patients and practitioners. So if you're gonna look at folate, for example, most labs use like LabCorp and get the serum folate level. Their normal level, it's if folate is above 5.4, something like that on the measure unit, they say it's fine. And if it's below that, is deficient. It's my opinion as a functional medicine practitioner that an ideal level of folate would be 10 or above. So
10 or above.
yeah, so that's the number one thing on the majority of the lab units now, which is LabCorp uses that. Now there's some other labs that use a different measurement unit that the folate levels are like 700.
Okay.
So my take is if the normal labs we're doubling, that one you should at least to have an ideal level of folate. Let's say if it's 700, you want to add 20 or 30% above that to have an optimal folate.
Optimal.
Yeah. So if your folate levels, let's say 10, which I think is optimal, 10 or above. If your level comes up at 10, well, I think we should be a little above because that fluctuates. So you can easily drop to a 9 and then you'll be below optimal.
Mm-hmm.
Makes sense? You want to have a little bit more than minimum, right?
Right.
You
Right.
have a little cushion. So, okay, with that said, so that's the number one thing. And by the way, I wrote an article on how to calculate folate levels. It's on the website. People can read. It's on the
Okay.
MTHFR
The MTHFR doctors site.
Yeah.
Yeah. Okay.
You can read it. So I'm just gonna go over real quick because I think it's very important. So when you read that's the number one marker for methylation, right? Folate. So you take the blood test, and then let's say your folate comes 10 or 11, and you're like, oh, okay, I'm good. Oh, not so fast. But when you measure folate, you're measuring all types of folate. When you measure serum folate, all types of folate, including unmetabolized crude forms of folate and unmetabolized folic acid, and including some methylfolate too. It's all combined.
Mm-hmm.
So your body still need to metabolize that. It still need to break that down into the usable form, which is a methylated form of folate.
Okay.
Now, if you have the MTHFR mutation, depending on your mutation, you could have a deficiency of 70% of your ability to break folate down.
To break it down.
Yes. So I like to play on the safe side. So let's say if your level of folate is 12 and you think you're good, but you have the worst mutation that you can lose about 70% of your ability to break that down. So at the worst case scenario, you only have 30% of that. Because,
Okay.
right? So if it's 12, 30% would be 3.6, something like that.
Okay.
It's way below 10, right?
Right.
So your folate is not okay. But
Right.
another person that does not have an MTHFR mutation and they're able to break everything down, the 12 is okay for them.
Okay. And
so the importance of measuring, of testing for MTHFR mutation.
And I mean, I guess there's no way to really correct that ability to break it down. That's not something that's not a variable that could be changed. That's based on your mutation, and that's how that is.
Yeah, your DNA is not going to change.
Right.
So if you have that mutation, you're
Right.
born with that, you're going to die with that mutation. So
Mm-hmm.
you cannot change that, but you can fix it very easily by taking methylated folate.
Methylated folate. Okay.
Yes. So so that's why we have, we have a lot of people that said, okay, so I got the mutation. Now what do I do? So
Yeah. Right.
very simple. You take the methylated folate, which is either if you take a 5, there are different forms of folate. Is either a 5L or 6S. Those are the best form of the methylated folate.
5Ls
or 6S. We do have one of the forms. We do have some vitamins and supplements available on the site now to help people that want to get it. So we have a very good formula for methylated folate that they can get, and have a table there based on their mutation. It's like a starting point for them to take. Although the best way is you do a blood work, you see your folate levels, you calculate that based on your MTHFR mutation to see if you're low or high, and then you take your folate until you get to a good optimal level, and then you just maintain.
Okay.
Now, people are not going to be doing blood work every month or even 2 months.
Right.
People go once a year. So that's why we put a table of recommendation based on your MTHFR mutation. At least you can take some methylfolate, and then most likely you're going to be on a good level when you do your yearly checkup. You make sure you ask a doctor to check for folate, and I also recommend B12. Check for B12 and vitamin D, very important for your health. And then you're always good. But I wanted to bring that up because some practitioners, they don't pay attention to that, the serum folate. That is not what the body is utilizing.
Okay.
Depends on MTHFR mutation. So you have to calculate. If you don't know your MTHFR mutation, there's no way to know if the folate you have is good or not.
Okay, so great. So how do you determine your MTHFR mutation?
So you take the MTHFR test.
Okay.
In our site, we develop a cheek swab.
Oh, okay, so you can do it at home.
Testing kits. So people can go on the MTHFR doctors and order the home testing kit. They don't need a doctor prescription.
Okay.
Nothing. Just order it at home. They do the cheek swab, send to us within 2 weeks. We get the results. Then they know their MTHFR mutation, and that will never change. It's
right.
one test in your entire life, and that's done.
Okay. And how can you take too much methylated folate? Can you overdose on it?
Yes, you can.
Okay.
And how much is too much?
Yes.
So most of the time, if you take the recommended dosage for 90% of the people, it's fine. Now, there are some people that even if you take a little bit, they're going to get, too antsy and have anxiety. They're not going to do well with that. So I want to give a good piece of information for if you take methylfolate and you don't react to it well, you stop taking it and take niacin.
Niacin?
Niacin is the antidote for a reaction because of methylfolate. Okay, about 100 milligrams of niacin. And then, you're right now. Okay, but 90% of the time people don't react to it. But some people may react to even a little bit.
Okay.
And we don't know who's going to react. But as I said, it's only going to be a small percentage. But at least they know that. If you overreact to everything, well, maybe you should have a little niacin at home. And then that's one reason, if it's the antidote for methylfolate, So I don't like having niacin on a formula that has methylfolate because it's kind of countering. So that's why I like the formula we have in our site because it doesn't have that. Now, if you react to it, you just stop right away, methylfolate, take a little niacin, and neutralize it.
Yeah.
That's great.
Right.
Okay. Now, too much folate. Oh my God, I've had people that come in. I mean, the usual dosage, you go from like 1,000 microgram, which is like 1 milligram, to like 2,500, 3,000 microgram, which is like 3 milligrams. Oh my God, I have people that they're taking like 30,000, 40,000.
Right. Okay.
That's too much. It's not dangerous per se that if you take that high that you're gonna get intoxicated and need to go to the ER. It's not dangerous like that, but it will throw your body into overmethylation. Will cause a lot of problems. So you have to start slow. And I think the prescription dose for folate starts at 5 milligrams and go to 15 milligrams. That's prescription.
Yeah.
Most of the time, you don't need that.
Okay.
And the prescription you need to get from a doctor, obviously, it's prescription. Mm-hmm. Most of the time, you don't need to. You take the supplement, you order, and you take a dosage, you're fine. 90% of the time, you can help to regulate methylation. Although I will say, because a lot of people think that methylation is always like the root of all the problems. No. Methylation is almost always part of the problem, but it's almost never the only problem.
Okay.
There are always other things that are going on in the body, so you need to look at everything.
Yeah.
If you forget methylation, you're forgetting a very important part in your health. So we need to take a look at that. It's very important. But if you only address that, most likely you're not going to be able to solve your health issues. You have to look at everything else.
You have to look at everything.
It's just a part of the process.
Yeah.
Okay.
Well, I want to tell you that it's already just a kind of a shift in understanding for a lot of health people in conventional medicine and health care providers. I hear so commonly people say he or she has the MTHFR mutation. Like I'll hear this often in like as we report to each other in the hospital. Mm-hmm. So just understanding that it's not a mutation, but there's different mutations mm-hmm. is a correction in the understanding of MTHFR.
Yes, there are two main alleles in the MTHFR that we look at. It is the MTHFR C677T and the MTHFR A1298C. Those are the two main ones. Mm-hmm. And within that, you can have several different mutations
within those
that it may make you lose from 20% up to 70% of your ability to break down the folate. Now, theoretically, you could have other mutations that could make you lose up to 80% or up to 100%.
Okay.
Now, I have never seen that, and the reason why I think I've never seen those mutations, and I have discussed that with different researchers in the field, and we agree that the reason why we don't see that is because if you lose 100% of your ability to metabolize folate, the fetus won't survive.
Yeah.
So, it's not a viable fetus, and then you're not going to be alive. So, now, there might be a mutation that you may lose 80%, and there are people alive I haven't found, but I suspect that there will be a lot of health issues with that individual. But I haven't seen any yet. And sometimes I have people that email me and they say, oh, I got 3 mutations, I got this. And I say, well, send me the results. Let me take a look at it. And they don't read it right.
Okay.
Don't have exactly the mutation that will make them lose, over 70%. I haven't.
Do you think it's common? Do you think that mutations of MTHFR are common?
it's a good question. And there's about 80% of the population have one MTHFR mutation.
Okay.
It's that common.
Well, and so
Now,
it's
I'm not talking about the one that you lose the most. I'm talking about the one that you lose 20%.
20%.
Minor mutation.
Right.
Now, I don't have the breakdown on every mutation in a percentage.
Yes, of course.
80% they will have a mutation. They could have one that lose 20%, they could have one that lose 40%, they could have one that lose 60%, or they could have one that lose 70%. 80% of the time, 8 out of 10, they're going to have a mutation. Only 10% of the population don't have any mutation. They're the lucky ones.
Yeah.
Have any mutation at all.
Right. But your health, so if 80% may have some type of mutation, your health can be impacted even if it's not the same as someone who has more mutations, more like less ability to break down, to methylate, but you hear what I'm saying? Like, your health can still be impacted,
yeah.
even if and I just, because of that number, it's just really interesting that this is such an anomaly, we don't have much discussion or understanding of this in the hospital setting. Just really.
Yeah, and I want to address, once you say that, there's so many people, I want to address one of the points that I've heard of people that discredit MTHFR mutation. They say, well, some of the people that do enough study to know, well, a lot of people have, they say, it's so common that everyone has, so it's not a problem. Right. This is not a good argument.
Not a good argument.
It's like saying, everybody has stress, so it's not real.
Not a problem.
When we know that stress, even though 90% of the population are under stress,
yes,
it affects your health. Now, some people deal with stress better than others, right? Right. So it doesn't affect the same thing with MTHFR mutation and methylation. Some people their bodies deal with the mutation better than others. So it doesn't mean that just because everybody have, or 80% of the population have, that it's not important. No, it is important. It's just that some people, maybe they have better diet, maybe their gut is functioning better, maybe they're less exposed to toxicity. There's so many other factors that they will deal better with their mutation, and they're okay. And other people, that it's when the people that have other things are breaking down. That's why I say it's not only the MTHFR.
Sure.
Other things are breaking down, that the mutation will be of a bigger impact.
Right.
Because all of us, if their gut is not working, and the gut is like the number one cause that I see in the clinic, it's a gut issue. So if your gut is not working well, you're not going to absorb the food that you eat. You're not going to absorb well the vitamins that you take.
Right.
You're not going to absorb well herbs that you take. So you're not going to absorb well everything.
Right.
And then it compounds. Now you have an MTHFR mutation. Now you have, and then you're going out and you're eating and get GMO. You have other toxicity. Now your body cannot detoxify.
Right.
And then it's a bigger problem than somebody that will have a mutation, but their gut is working much better. So they're able to detoxify. So they have a better lifestyle. So there are other factors that will always come into play.
Okay. So it's interesting. Okay. I listened to why you got involved in this, which is great, because you heard hope at this epigenetics, this conference. What has kept you going in this kind of, I don't want to say marginalized, but it is kind of marginalized, this specific branch of health? Like, what has kept you here?
Well, one thing is to be able to help people.
Okay.
And then when we address that in combination with everything else, the patient gets better.
Right.
So this is awesome. And even though you say that, there's always the naysayers, the marginalized, but the majority of doctors that I talk to, they're open to it.
Right.
Maybe they don't know about it, But they're like, oh, because once you talk to them, and it's like, yeah, that makes sense.
Right.
So I have found, at least here in Los Angeles, and that the doctors are very open
Yeah.
to, to learning that. Maybe they don't understand enough, they don't have the time to study and research,
Right.
but they're more open. Now
Yeah.
there are always some people that I think the most dangerous, some people that have some knowledge but not enough.
Just enough to hurt themselves.
Yeah, and then they're like, well,
Dangerous.
that's what I say. Well, it's not so important because everybody has it. Well, we got to look at a different way. It is important. Or they say, we just look at homocysteine.
Yeah.
Not
Oh,
so,
right.
like I explained, you have to look at folate, and the reason why you look at folate, most folate, when you test, it's all folate. You're not testing for methylfolate. It's everything together. So you have
Yeah.
to estimate. If you don't know your MTHFR, you can't estimate.
Right. Well, my dad would call that. My dad would call that knowing just enough to be dangerous.
Yes, exactly. So sometimes, yes.
Right.
Um,
So this is what's kept you going is seeing people get better. Can you think of any cases or specifics that really stood out to you in these years that that really just was like a great improvement after either folate or folate plus the other things that you do in your clinic? So that would be the genetic studies, the nutrition, the
yes.
Chinese medicine.
Okay, so something that stands out for me, it's because I always combine everything, but in my opinion, is the notion that if we address that right, I believe we should be able to reduce the risk of autism
Oh,
in the country. And I'm going to explain why. And that for me stands out because I see with my studies, if you go to the Center for Disease Control and you look at statistics for occurrence of autism in 1987, it was 1 in 10,000 babies. Okay.
Right.
And then you look in the Center for Disease Control website, the occurrence rate for autism in 2014. That's, I think, is the latest updated that I've seen, is 1 in 67.
Mm.
And then I'm going to explain, in my opinion, in most of researchers in this field agree, right about the early 90s, the doctors start prescribing folic acid for all pregnant women. Okay,
Okay.
to
Right.
prevent birth defect.
Sure. Right.
They
Right.
cleft palate and all that.
Yeah.
That does the job.
Right.
It does the job really well. But right about that, and then as you look at the progression of autism, and that's not the only cause. There are other factors as well, because autism has to do is developed in utero and has to do with brain development, which is directly related to detoxification. Okay, to toxicity in the brain development, and methylation is directly related to your ability to detoxify. And what happens when you're taking folic acid and you have a homozygous mutation on MTHFR, for example, so you're only metabolizing 70% of that folic acid. I'm sorry, you're only metabolizing 30%, you're losing 70%.
Right. Okay.
What happened to the 70% that your body is not able to utilize?
Yeah.
It becomes endogenous toxins. Now your body needs to detoxify. Okay, so that, in addition to all the other toxicity that happens on a person's body, it becomes too much. And I think that's it's a big part of the increase of the rate of autism in this country. So it's my belief that if I could sit in front of the FDA panel, I would. And if they change the recommendation from folic acid to methylfolate, it would reduce significantly the occurrence of autism because of the MTHFR mutation.
Wow.
So, yeah, for me, which is like that is mostly related to this. So whenever I'm working with pregnant women, the first thing I do is, okay, so what are you taking? Let's check your MTHFR. If they can take folic acid, replace to methylfolate. Even if you have 20%, I better be safe than sorry. So change it. So they'll get the same benefits because they're getting, they're taking folic acid because they want the folate.
Right.
So take the later folate, and so I'll make sure that is happening.
Okay.
Yeah.
And you like to do that really based on the lab work and the mutation that they have that we know about. Like, so they get a test on which mutation they have.
Yes.
And then what their actual folate level is.
Yes.
Okay.
Then, okay, based on that, and then we know how much they need. That's really the best way of doing.
Right.
You know the mutation, you know how much you're able to break down the folate, and you do the blood work, you measure serum folate. Okay, so now let's calculate. Oh, your body only has that much. So you take until you're above 10. I like to have, Cushing. So if you're like 15, say, okay, great. Same thing with B12. The functional range, I like to see people with B12 levels of 800 to 1200. I know the most labs, they show normal levels of B12 like 300 something to 800 or 1000. I like a little higher.
Okay.
And if I may share, I know it's not MTHFR, but it's so important. Vitamin D, for example.
Vitamin D. Yeah.
So many people, like 90% of people I see, they have low levels of vitamin D.
Right.
And when I mean low, I mean functional level, which is optimal level.
Yes. Let's talk.
Normal range, the lab normal range, it's usually 30 to 100, but the functional range, the optimal level for vitamin D, they're around 60 to 120.
Wow.
Now, a lot of research shows that people with high levels of vitamin D don't get cancer. So and vitamin D is important in so many functions in the body. I like to have people, above 60, around 80. Everyone that I test, they're like 32, and sometimes if they're over 30, the doctors say you're normal.
You're good, yeah.
You're optimal.
Right.
So that's like very important for overall health.
Well. So, and this was a while back. I remember a neurologist who was talking about how she likes higher levels because she's like, I didn't care a lot about vitamin D, but she was getting, her patients their migraines were going away with more of that higher level than our current range of normal right now. So she was one who was always recommending a higher level of vitamin D. And I know like sometimes like there's optimal and then there's your optimal as a person, as an individual too.
Yes, that's true. And then there's one question that I didn't have the answer a few years ago, and which the question is, how much is too high on vitamin D?
Oh yeah, that's a great question.
Yeah, that's interesting because everyone that comes in the clinic and we test, they're always low, right? So I never had to think that. So I want to share this because it's not a common thing that people see.
Right.
So a lot of practitioners like myself, maybe that they don't have the answer those who have.
Yeah.
So I had a patient that came in and I tested her, and her levels were 150.
150?
Yeah.
Wow.
And I was like, wow, is it too much? And I didn't know. So I called one of the doctors that I coach on MTHFR.
Yeah.
And she is an ophthalmologist, and she deals with autoimmune, and a part of her treatment is high levels of vitamin D that he gives. And so I knew that she knew a lot on that. So I gave her a call and I said, well, now I need coaching. So I'm coaching on MTHFR. I said, I have a question. How is that 150? Is that too much? And she said, no, don't worry about it. She has patients that, the levels during the treatment was like 300, 400.
What? Oh, wow.
Yeah. And that was during the treatment. I do not recommend
that.
But because that was like during the treatment. So my recommendation for Vitamin D levels, 60 to 120. That's the range. Try to keep between 80 and 100. And even if you keep it 100, if you look at the LabCorp, 90% of LabCorp, the lab range is 30 to 100.
Right.
So let's keep it close to 100.
Fair enough.
So
Fair
it's
enough.
very safe. It's going to be a good level.
Mm-hmm.
So you don't need to worry like, oh, if it goes a little high, you just stop taking vitamin D and then it comes back down. But, you know, for liability purpose, always consult your doctor.
Yes, I know. Right. Of course. Of course. Okay. So based on this talk, a person could go their whole lives not knowing about what their mutation might be, and it could impact their health significantly.
Mm-hmm.
And I want to hear just a couple of things, like what could that look like? So if a person has gone their whole lives, they're an adult, they're in their 30s or 40s or 50s, and they have a mutation that may even be significant, and they don't know that, what could their health look like? What could that picture look like?
Yeah, so that's the thing. That goes back to the question. It depends on how everything else in their life is.
Okay.
So they could have the homozygous, they could have the worst mutation, and their health could look fine.
Okay.
Oh, everything's fine. They have no symptoms, everything's fine. Until something breaks down.
Okay.
And then the mutation, it's going to have a greater impact on them.
Okay.
Especially in the controlling gene expression.
Mm-hmm.
In other words, I'm going to give an example. I gave a lecture one time, and somebody from the audience, she said, wow, that's probably what happened to her sister. Her sister was super healthy. She was like a yoga teacher, excellent diet, everything. Always she went to the doctor to do like a physical. Everything was always perfect.
Okay.
But she never checked for MTHFR, so she had no idea about her methylation. So one day, because of genetics, right?
Yeah.
She had a cancer came out of nowhere.
Okay.
Okay. And she died. And here comes the question. If methylation controls gene expression, maybe she had a methylation problem and she didn't have enough folate. She wasn't methylating well, but because her lifestyle was so good, but she had those genes.
She did have the genes
from the family,
right?
From her family. So you might have a predisposition for a disease in your family.
Yes.
But you're not turning off those genes because methylation is not working well. So your health is good, you're going great, and you're not feeling anything.
Right.
But your methylation is not turning into a gene, and then the gene is going to get expressed at some point.
Right.
Get the disease, you're like, wow, it came out of nowhere. How many times we hear so-and-so was so healthy.
So healthy.
Out of nowhere.
Right.
Right?
Right. Absolutely.
And I think in those cases, it has to do with methylation, probably, most likely. Because probably genetics, and then if you just had worked on methylation, you would have prevented. Another example is like you have, like usually with a young person,
right,
like a young adult, that, oh my God, they can do everything. They smoke, they drink, they have the worst lifestyle, and they're fine.
And they're fine.
Because their body, they haven't broken down to the point that they're going to feel it. Most of the time, your body needs to lose function about 30% before showing up on blood work and so forth. So they're not feeling, the body's breaking down, but they're not feeling it.
Right.
Everything is like, oh, everything's fine. Well, no, everything's not really fine. They just don't know it. They rely on symptoms.
Right.
I had recently, somebody came in and everything was fine. Okay, health fine. So I checked blood pressure. 230 something over 140.
My
Like, do you, and he's
Oh,
like, do you, and I'm strong, big man, strong, do you have any symptoms? No. I feel fine, I'm great, I just wanted to check. And I was like, wow,
calling you
what can
an
you do about that? And I said, what insurance do you have? Oh, I have this. And okay, so this is what I want you to do. This is what I can do for you. I want you to get in the car right now and go to the emergency room.
emergency room. Ambulance.
I mean, yeah, just drive there. And then I called the person in the evening. I said, oh, so how did it go? They said they admitted him and lowered blood pressure slowly. Because,
Right.
I mean, he could have had a stroke. Any
Right. Right.
So you can have an MTHFR and go all your life without an issue. But then again, if you have if you have a genes for particular conditions that you have in your family. So if you have diabetes in your family, I'm going to give you 4.
Thank you.
Either diabetes,
Yeah.
heart condition in your family,
Heart condition,
or cancer,
cancer,
or mental illness.
mental
One
illness.
of these 4. Okay. If you have one of these 4 in your family, look at methylation, because you can turn off the genes on most of those. There are some, for example, the BRCA genes for breast cancer. If you got a specific one, then there's nothing you can do. But for the majority of cancers, for the majority, and for the other conditions, you can actually control the expression of the genes.
Mm-hmm.
If you have one of those 4 in a family, test for MTHFR, control your methylation.
This has been amazing to me. I really, I am so happy that I found you.
Thank you. Nice.
I want to, before you go, I want you to just mention one more time how people can get more information about this. I will include it in an email as well. But I want just for people to know how to get more information.
You know, mthfrdoctors.com.
Mm-hmm.
They can read articles about it. The article I wrote on how to calculate folate, they just search for that. It breaks down exactly how they calculate folate. They can order MTHFR testing kits. They can test at home.
Yes.
They can order vitamins for methylation, so they can get a lot from the site. So that's a good place to start.
Perfect. Thank you so much.
You're welcome. Thanks for inviting me.
Thank you again.